My name is Andrea Maher. I've been a consultant dietitian most of my career. I am currently at the Iowa Veterans Home as the Quality Management Director. I've been a dietitian for 25 years. About 10 years total have been at the Iowa Veterans Home, but it was divided time, first as a clinical dietitian. And then in my career, I've been majority of it been a consultant dietitian. I worked at the Flex Specialty Hospital in the Quad Cities when they first opened, and currently living in Huxley, where I've done consulting. And then I've returned to the Iowa Veterans Home, first as the Food and Nutrition Services Director for 3 years, and now in my quality management position. So I'm going to go ahead and just jump right in. Today we are going to talk briefly about the MDS process, and it is a level 1 presentation. But I think sometimes when we have been seasoned for a while, we kind of forget about that RAI manual, and it is good to review it once in a while and remember what's in there, and to always use that as a resource when we get stuck on something. We do have several students here today, which is wonderful. We have students from the University of Iowa and Iowa State. And I can tell you it's been an interesting year. I have had students for a dietetic intern in food service, but it was done virtually. And that makes it very challenging to get medical nutrition therapy as an intern, because a lot of facilities weren't even letting students in. So I hope this presentation will be beneficial to you. So our objectives are to describe how to conduct an assessment of a resident's nutritional status utilizing the Resident Assessment Instrument, or the RAI, and how to code Section K correctly and accurately. What does MDS mean? It stands for the Minimum Data Set, and it's a tool for implementing standardized assessments and for facilitating care management in long-term care facilities. By law, all residents in certified nursing homes must be assessed according to this prescribed instrument. MDS 3.0 is our current standardized tool, and the MDS contains items that reflect the acuity level of the resident, including diagnoses, treatments, and an evaluation of the resident's functional status. The MDS is used as a data collection tool to classify patients into payment groups. In other words, how does the facility get reimbursed for the value of services provided? The MDS assessment tool is completed for all residents in certified long-term care facilities. These assessments are completed by various team members of the interdisciplinary team and are used for resident care planning, Medicare and Medicare payments, and monitoring quality of care. The assessments are completed within 14 days of admission and every 3 months or more often, depending on circumstances like skilled care or if there's a significant change in a resident's status. The information entered by each discipline is transmitted electronically then to the appropriate state MDS database. One term is important to know will be ARD, and I will be referring to this. So the assessment reference date signifies the last day of the observation or the look-back period. So when you enter a facility, or if you're new at long-term care, a very important thing will be during your visit right away would be to ask what residents are due for assessments, and you're going to need to know their ARD date so that you can begin your work. Most of the MDS data items do have a 7-day look-back period, and so we're going to give an example. If today is the ARD, February 19th, then the look-back frame would be from February 13th up to today, February 19th. There are specific time frames when assessments need to be completed so that the MDS nurse then can submit the information on time. This is just a snapshot picture of what the MDS 3.0 RAI manual looks like. On the resources that you got from Kathleen, On that front page under the second bulleted point under CMS, on the bottom there she has that resource. So it's a download, and the most current edition of the RAI manual is from October 2019. There was an update scheduled for October 2020, but that has been delayed. So it is good to always make sure, if you put icons on your computer, that is nice, but you do have to be aware that if there's an update, you might miss that if you're always going to a shortcut. On the bottom here, if you go to cms.gov into Medicare, then you can also find the most recent edition of the RAI manual that way. Okay. There's a lot of information in that RAI manual. We're going to concentrate today on those minimum data set questions, and then also kind of briefly talk about the CAAS process at the end, and that will lead into part 2 into Amy's presentation next. I did include just one handout, that is Section K, Swallowing Nutritional Status tool, and that is was on the something you could download there before the meeting. And this is what I'm going to focus my half an hour on. So Section K is on swallowing and nutritional status. This section is to assess the conditions that may affect the resident's ability to maintain adequate nutrition and hydration. The first set of questions there are regarding swallowing disorder. For this section, you're going to need to do a little bit of interviewing. You're going to want to ask the resident if they've had any of these conditions, or whether it's been a loss of liquids from their mouth, if they've been holding on to food in their mouth, if they can't answer that, if they've had any coughing or choking or difficulty with pain with swallowing. You'll also want to make observations, if you can, at the dining room. And you'll also want to review the medical record and ask staff if they've observed anything. You only code these, you would only check mark that these apply if there was one of these signs or symptoms were reported and then, or documented or observed during the ARD period. So if it occurred on February 10, outside of that, you would not code this. If it occurred on February 20, the day after the ARD period, you would not code that. Also, if the symptom only occurred once during the ARD, you still code it. The next section is on height and weight. Height is obtained upon admission and measured in inches. Trained staff need to measure and record the resident's height annually. And you round the height measurement to the nearest whole inch. So if you had a resident that was 62.5 inches, you would round that to 63 inches. If you have a resident that is 62.4 inches, then you would round that to 62 inches. For the weight, weight is entered in pounds. Scales must be calibrated and accurate, and you want a consistent process. So specify the type of scale that should be utilized and indicate what the patient should be wearing. Ensure that the patient is, you're not getting the weight of an orthotic or a prosthetic. So if a resident is wearing that, you're going to want to make sure that that prosthetic or orthotic is subtracted from their weight at all times. Same thing if it's in a wheelchair. You don't want to give them the person with the wheelchair, so you need to have accuracy in that wheelchair weight. So each time that you get the correct weight subtracted from that to get their true weight. If the last recorded weight was taken more than 30 days prior to the ARD date of this assessment, or the previous weight is not available, then weigh the resident again. If the resident's weight was taken more than once during the preceding month, record the most recent weight. If a resident is on a daily weight, then you would want to use the last weight obtained during that observation period. So if they weighed every single day during that 7-day look back, you would use the weight from today, from our RD date if it was 219. If a resident cannot be weighed, let's say they're in extreme pain or they refuse to be weighed, then you would code as a dash. So we are going to round again to the nearest whole pound. If the weight is 0.5 or more, or round down if the nearest whole pound is 0.4 or less. So a weight of 152.5 would be rounded to 153. A weight of 152.4 would be rounded to 152. And if a resident is on hospice and no weight was obtained 30 days due to extreme pain, you would code as a dash. The next set of coding instructions address weight loss and weight gain. So on your paper there, we'll be going down to that next section. This item compares the resident's weight in the current observation period with 2 snapshots in time. At a point closest to 30 days or 1 month preceding the current weight, and at a point closest to 180 days, 6 months preceding the current weight. The resident may experience weight variances in between the snapshot time periods, and this is not something that's captured on the MDS. So it's just a snapshot in time comparing 1 month ago and 6 months ago. If you have a new resident, you will want to ask the resident or family about weight loss or weight gain over the past 30 and 180 days. You can also consult the resident's physician and transfer documentation and use this information when comparing the admission weight to the weight 30 days ago and 180 days ago. So if the records show that there was a weight change in 6 months, you would code that there was a significant loss during that time period. If a resident is losing a significant amount of weight, the facility should not wait for the 1 month or 6 month time frame on the MDS to address the problem. So anytime you have a resident who is having a significant weight change of 5% or more in 1 month, 7.5% or more in 3 months, or 10% or more in 6 months, this should prompt a thorough assessment in the resident's nutritional status in the medical record, and interventions should be reflected on the care plan. So let's see, back up here. You would code a 1 if there is a physician-prescribed weight loss regimen. A weight reduction plan ordered by the resident's physician with the care plan goal of weight reduction. So let's say that someone is on a calorie-restricted diet or a weight loss diet, then you could code it as a 1 on the MDS. This would also include a planned dialysis. So if a doctor ordered Roxulin and you have a statement that that was weight loss was planned or intentional, you could code that as a 1. So make sure that it's from a physician statement or you have something to back that up, and make sure that you document that. If the weight loss was intentional, unplanned, then you would take it, you would code that as a 2. Moving along to weight gain then. For weight gain, we would trigger 0 if the weight loss didn't, if there was no weight loss, 1 if it was a physician prescribed weight gain regimen. So if someone was purposely, on a supplement with the intentions of promoting weight gain, and that was documented, you could code that as a 1. Otherwise, it would be coded as a 2, that it was not a physician prescribed weight gain regimen. So for behind the scenes, our electronic programs do mathematically round weights, are coding the BMI behind the scenes. So using that height and weight that you entered, there would be a BMI calculated. If a BMI is less than 18.5 or greater than 24.9, it will trigger the CAT on the MDS. And we'll talk about that a little more later. You do want to mathematically round weight before completing the weight loss calculation, and that is specified in the RAI Manual. I would like to just go through and provide an example of what that would look like. Here is, the thing is we have a lot of electronic programs now where our nurses enter the weight. If the weights are not rounded beforehand, you could choose to either use a separate Excel sheet to round the weight, or do that on your own, just to make sure, especially if you have a weight that might be around 4.9% or 5.1%, you might want to double check on using a rounded weight for the MDS coding, because that is what's being asked of us. So I have 4 residents here, and it's the month of February here, and I have resident A's weight is 175, resident B's weight is 217, C 130, and resident B 184. So resident A, when we compare the February weight to the January weight, I would use the current weight minus the previous weight of January, divided by the previous weight, times by 100 to get that percent. And resident A shows a significant weight loss of 5.4% in 1 month. So on the MDS, depending whether that was a planned or unplanned weight, I would code that accordingly in the weight loss section of the weight loss. Resident B does not show any changes, significant changes in weight, so they would be a 0 or a no for weight gain or loss. Resident C does have a significant weight loss, but it is at the 3-month period, the 90 days. And that was from comparing the February weight to the November weight. As you notice on the MDS 3.0, there is not a category for 3 months. So this would be something as a dietitian, I would document that the resident had a significant weight loss in 3 months, but that would not be reflected on my MDS section K. Resident D, comparing their current weight to the August weight, shows a significant weight gain of 10.2%. So depending on whether that was physician prescribed or not, I would code that accordingly on the weight gain section. Next, we have section K on nutritional approaches. These nutritional approaches address nutrition and hydration received by the resident in the last 7 days, either at the nursing home or the previous facility, like usually a hospital. So we're going to want to review the medical record to determine if any of the listed nutritional approaches were performed during the 7-day look-back period. And I have there in bold, but during the last 7 days. Review the medical record to determine if any of the listed nutritional approaches were performed during the 7-day look-back period. Sometimes the reference date, the ARD assessment ranges selected by the MDS nurse may include days while the resident is not a resident, and that is why they have that category. So let's say, for example, we picked an ARD date of today, 2/19. Possibly that resident might have been in the hospital for February 13 and February 14 and returned to the facility on February 15. And that's important to look back and know which days count for hospital days versus days at the home while a resident. I'm going to first just jump to the section under nutritional approaches, the mechanically altered diet and the therapeutic diet first. Mechanically altered diets are defined as a diet specifically prepared to alter the texture of consistency of food to facilitate oral intake. So examples would be a period diet. It could be a regular diet with ground meat, or someone on thickened liquid. A therapeutic diet is a diet intervention ordered by a healthcare practitioner as part of a treatment for a disease or clinical condition manifesting an altered nutritional status. That's a mouthful, and that comes from the RAI Manual. So it's a diet that is used to eliminate, decrease, or increase substances in the diet. So, for example, it could be a low-fat diet, low-salt diet, diabetic diet, cardiac diet, low-sodium diet, modified renal diet. A supplement isn't necessarily coded as therapeutic. But if you, let's say a resident was put on a supplement with the diagnosis of protein calorie malnutrition, then the malnutrition would be a reason that it would be therapeutic. So you could mark that the resident is on a therapeutic diet in that situation. Or if they're on a special supplement for diabetes, you could code that as therapeutic as well. Also, if there are food elimination diets related to food allergies, this also can be coded as therapeutic. I have gone round and round with dietitian peers on some of the coding for therapeutic diets. I think there's a lot of gray fuzzy area, but I think bottom line is, whether you make a chart or you seek your professional advice, but try to be consistent with how you code. And it's helpful if you have, if you're under a corporate umbrella and you can ask for consistency, but it is important to code consistently and explain your rationale for why you did what you did. And it's amazing sometimes you can go back when you chart, you take the extra time and you chart those notes, they come in handy because a consultant sees a lot of residents, and it's helpful to have notes as to how you came up with some of the coding that you do on the MDS. I'm going to move into the top two there, the parental IV feedings and the feeding tube NG or PEG. Parental IV feeding includes fluids for nutrition or hydration needs. So this could be someone was on a TPN during at the hospital or at the home if you do that. It could be some IV dextrose that was given continuously or intermittently, and IV piggyback. It is important to look for an active diagnosis of dehydration, though, when you code for those items. Prevention of dehydration should be clinically supported by documentation in the medical record. You do not code for IV medications, reconstitution of dilution of meds for IV administration, IV fluids administered as part of an operative procedure, or IV fluids administered solely as a flush. I would say that when someone comes up from the hospital and I'm trying to look at a piece of this, this is probably where I use my RAI manual the most. I don't have, sometimes I don't have all that memorized, or I'm just not sure. And so whether it be the RAI manual that the home has, I pull, or I just look up the reference, I often seek the advice of the RAI manual when it comes to hydration. In the feeding tube section, this should not be coded as a mechanically altered diet unless the person is receiving a tube feeding and on an oral diet. So if they're just on the feeding tube, you would not code a mechanically altered diet. And then the feeding tube would not be considered therapeutic unless the ENTERAL formula is used to manage a problematic health condition. So if you had, if you did have someone on a very specialized feeding, if it was especially for the diabetes, or you had them on something special for a renal condition, then you could code it as therapeutic. Otherwise, you don't trigger that one either. I do have some examples to end with. Mr. H is hospitalized for mental status change and a UTI. He returns on an antibiotic, and his look-back period includes 2 hospital days on skilled care. The medical records from the hospital documented inadequate fluid intake with signs or symptoms of dehydration. Documentation shows IV fluids were administered throughout the hospital visit. Would you code for parental IV feeding on the MDS? And the answer would be yes, while not a resident. The very bottom section there is percent intake by artificial route. Only complete this section if the parental IV tube columns are checked above. So you would address while they're a resident at the facility and during the entire 7 days. So we'll look at an example of that. Mr. B is being tapered off a tube feeding. His calculated needs are 2,000 calories a day. We've already had that calculated. You've added up the totals, looked at the enteral feeding they are on, and figured out how many calories. And the total amount of calories for his 2 days in the hospital during the ARD 7-day look back was 4,000. And while at the nursing home, in the last those extra 5 days of the ARD period, he received 6,250 calories. So there was a total of 10,250 calories during the ARD. What proportion of the total calories did the resident receive via tube feeding? First, we're going to look at while not a resident, or I'm sorry, while the resident, while they were a resident. That's the question. So the total while a resident were 6,200. I would take those calories divided by the total 7 days of the ARD period for a total of 886 calories. We know his estimated needs were at 2,000, so he received 44% of the proportion of his calories through the tube feeding while a resident. So on the MDS, we would code a 2 there as 26 to 50% of his calories came from that tube feeding. Then during the entire 7 days, we would take that total amount and divide that by 7. And we know that he had a total of total need for 2,000. So 73% of his total calories came from an enteral feeding, which then would be coded as a 3 for the entire 7 days. How many do I got a few minutes left here. Then we have to look at the end. There's average food intake per day by IV or tube feeding. So in order to figure that piece out, we would look at the total number of free water and flushes that were given at the hospital and while at the nursing home in those 5 days. So the first spot there is while they were a resident, we would take the total amount while a resident, which was 7,815 cc, divide that by 7 days to come up with 116 cc. On the MDS, they've asked too, whether you've had 500 cc's a day or less, or 501 cc's or more. And so that would be a 2. Again, the total amount received during those 7 days were almost 12,000, and divide that by 7. And then you would again be over you would code a 2, so 501 cc's a day or more. There are other sections in the MDS that you would want to be aware of. I didn't copy that one off, but Section L is oral and dental status. At one time, one of the question about difficulty chewing was moved from Section K to Section L. And so if you do have the nurse that does fill that out, I'm always very cognizant of that. So if during my interview with the resident, if they tell me that they've had any mouth or facial pain or discomfort or difficulty with chewing, point F there should be triggered on the MDS. And so I either go in there and code that myself and let the nurse know, and then I document that in my assessment, or make sure I let the nurse know that should be marked on the MDS. And then that will lead to the CAAS summary. Section B of the MDS is the CAAS summary. This will address the care areas that were triggered by what we put on the MDS items. And so from here, the RAI Manual will address the care area assessment or the CAAS process, what we're going to do next. Did we trigger something in Section K? Was there significant weight loss or gain? Did we trigger a therapeutic diet? Did we have any IV fluids, or was the resident on a tube feeding? Was there BMI, underweight or overweight per the standards of the RAI Manual? The information we entered in the MDS will then lead to the next step, which is the decision-making or the CAAS stage. This will be the foundation of our comprehensive assessment for the resident and will help with our upcoming care planning. And so we went from the red, the MDS, into the decision-making CAAS process.
that sort of thing. So our learning objectives today will be identify how to use the nutrition care process to build the resident-centered care plan, describe how to incorporate significant weight changes, enteral feedings, dialysis, and skin impairments into the resident-centered care plan. So FTAG 656, the Comprehensive Care Plan regulation, states that the facility must develop and implement a comprehensive person-centered care plan for each resident consistent with the resident's rights that are set forth, and that include measurable objectives and timeframes to meet a resident's medical, nursing, and mental and psychosocial needs that are identified in the comprehensive assessment. So, and then also in FTAG 692 for the assisted nutrition and hydration, it also talks about the care plan, and that the care plan must address, to the extent possible, any impaired nutritional status, reflect the resident's personal goals, preferences, and identify resident-specific interventions and a time frame and parameters for monitoring. So we get that information by doing our comprehensive assessment, and we're going to start building. One of the important parts of the care plan is making every effort that it is person-centered and not clinical-centered. I remember back in the day where every care plan started with potential for altered nutrition due to CHF, AFib, and they list all these diagnoses, and current practice is not necessary to do potential, because everybody has a potential for something. So hence person-centered. And we're going to make an effort to understand what each resident is communicating verbally and non-verbally, identify what is important to each of the resident, and even the representative as well, and with regard to their daily routines and preferred activities, and just having an understanding of what the resident's life was before they came to our facility as well. So goals per FTAG 692, the care plan should be updated as needed, such as when the resident's condition changes, the goals are met, interventions are determined to be ineffective, or as new causes of nutrition-related problems are identified. So if nutritional goals are not achieved, the care plan interventions must be reevaluated for effectiveness and modified as appropriate. Some examples of goals may include, but are not limited to, a target weight range, desired fluid intake, the management of any underlying medical conditions such as diabetes, kidney disease, wound healing, that sort of thing, the prevention of any unintended weight loss or gain. Weight stability rather than weight gain may sometimes be the most important short-term or long-term objective for that nutritionally at-risk or compromised resident. So at the end of Andrea's presentation, she talked about the CAAS and using the CAAS to develop a care plan. So when we're developing that comprehensive care plan, the facility staff must, at a minimum, use the minimum data set, or the MDS, to assess the resident's clinical condition, cognition, and functional status, and the use of services. And we have to look at those causes that are triggered. Documentation regarding these assessments and the facility's rationale for deciding whether or not to proceed with care planning for each area triggered must be recorded in the medical record. The facility is responsible for addressing these areas and must document the assessment of these risks, weaknesses, or needs in the medical record and determine whether or not to develop a care plan and interventions to address those areas. Residents are able to refuse their plan of care, and this will also need to be documented accordingly. So there are 20 care areas in section B that hopefully not all of those trigger. That would be a lofty situation. But CAA number 12 on nutrition has 8 cats. Section J is dehydration. From section K, there are potentially 6 areas that would trigger. Your BMI is too high or low, significant weight loss or gain, parental or IV nutritions, mechanically altered diet, and the therapeutic diet. And then it will also trigger if in the section K for number 12, if they have a pressure ulcer that is stage 2 or higher. And then number 13 with feeding tubes, that's pretty self-explanatory that they will trigger. Call number 14, hydration and fluid maintenance, has 8 cats that could potentially trigger. I don't recall many of the facilities asking me to do a call for dehydration, but currently I do have some nursing staff that will ask me to put my input into the dehydration if that was triggered, but mainly looking at number 7 and 8, parental IV feedings and then just feeding tubes. The call number 15 for dental care, this would be from section L, and that could potentially trigger as well for the status of their teeth, broken teeth, or anything like that, and hopefully they can get a dental consult in place. So with the call documentation, point-click care, I know, is widely used in the industry right now. So you get to section V and call number 12 is triggered, and it may look similar to this, but how do you fill it out? You know, how do you get to that second part of filling out what has quote unquote triggered? And so just note that written documentation of the call findings and the decision-making process may appear anywhere in the resident's record. There's no particular location or format that is required. So popular formats, as we have seen, are checklist with the summary analysis. There's a call review note summarizing and analyzing the findings, and no additional note or summary other than the routine chart documentation. But we also need to make note where you're going, where a surveyor or whoever's looking at these are going to be able to find that supporting documentation. But CMS does state that in some cases, it may be prudent to write a summary of the call information, especially if the assessment documentation in the record is incomplete, unclear, too scattered, or unfocused. It may also be useful to have the information summarized for quick reference as the staff. So here's just a snippet of what call number 12, and it has a summary. This is kind of an example from one of my current residents, and so I just put in the questions and comments, and from the input from the resident and the family, was to see my RD assessment dated on 2/1. The resident understands that he has had an increase in swallowing difficulties and declining SLP services or further diet modifications. So that's a pretty good summary of what was occurring with that resident at that time. And then my findings, and we'll talk about this a little bit more. We'll refer back to this slide. But this is when the mechanically altered call was triggered. There was some swallowing difficulty during the ARD assessment. And so when I've done my assessment, I have a portion that talks about nutrition diagnosis. And this is where this is the start of my care plan. So I literally just copy and paste my nutrition diagnosis into my analysis of findings. So this particular individual, the mechanically altered diet related to swallowing difficulty, has been seen by SLP, the date that speech therapy had looked at this resident, and that the diet texture and eating strategies do remain appropriate. And then a few other nutrition diagnoses. I know I didn't have to put swallowing and chewing as separate, but kind of felt it was important during this time with this individual's significant change. And then the call number 12 asks you for care plan considerations. Are you going to care plan these problems? And if you're not, why? So in this particular one, the care plan does address swallowing difficulties with a goal in place. Supplement use and weight goal is also in place, and just to see my RD assessment. And I know my dates don't match, sorry. So building the care plan, as I talked about, is using the nutrition diagnostic terminology that we have. It's been in place for many years, and some of the top ones that seem to be used in our facility is inadequate oral intake, the swallowing difficulty, undesirable food choices, unintended weight loss, those types of things. But sometimes you can have that there is no nutrition diagnosis at this time. And maybe that's happened at admission and you're not familiar with the resident yet. But in a few more weeks, give them a little bit of time, and there's probably going to be something that creeps up. So I don't use that very often. In fact, I don't know if I've ever used no nutrition diagnosis. So I did add this slide. There are a few slides that are not part of what was given to you, just because I was reviewing it last night. So just an example of this is what a care plan is going to look like: the date, the problem, the goal, the interventions. And we're going to focus right now on the problem. And just remember that a nutrition diagnosis can be turned into the problem. So if you have a diagnostic statement that states overweight related to resident enjoys extra items with meals and prefers to not restrict diet or calories at this time, it then can become, I am overweight and I do not want to lose weight. It's very specific and concise, and any person that's reading this care plan understands it. They may not understand all this clinical wording that we like to use. So that's what the iCare plans is meant to be, is that any person can read the problem, read the goal, and understand the interventions. And as you can see, also an unattended weight loss in this past year, as evidenced by 15-pound or 10% in 6 months. Resident reports this is a good thing, and I turned it into, I have lost weight this past year and I feel good with the weight loss. And that's what the resident believes. Here's a few more examples. I took one for a diabetic who had an elevated A1C and elevated AccuChecks and the need for insulin. And the resident does live with diabetes and they choose not to monitor what they eat. So pretty concise. The other thing is here on that second example is chewing or swallowing difficulty, and they have a supplement. And you know, it was suggested that maybe need to put what the supplement is and how many calories and how many grams of protein that supplement offers. In my, again, that diagnostic is in my charting. I don't put that in, I don't put how many calories or protein, but you sure can. But again, this resident I have difficulty with chewing and swallowing. I'm on mechanically altered diet. I do have difficulty with holding regular silverware, so I need adaptive equipment. And I have a poor appetite and require a supplement. And the list can go on and on and on. A few more examples as well. If you've got somebody with CHF that doesn't want a fluid restriction, has refused a fluid restriction, and doesn't want to eliminate their salt. Parkinson's, and memory loss. And we go back to resident preferences, concerns, and needs. So I don't have it on here, but I recently had a resident flat out say, I want to drink Diet Mountain Dew for all of my meals. And I guess I do have that. They don't want to consume water, and I like to consume soda instead. And we know that can possibly lead to dehydration down the road, but I have addressed it, and in my note also provided education about limiting. They're limiting themselves to their hydration status. So it's not about what I want, it's about what they want, and putting it into their words. And sometimes it may not look pretty or the best, but again, this is about the resident as well. So then we move into resident goals, and it's what the family and resident desires as well. So some examples, I can't want somebody to gain or lose weight. They need to be on board with that for it to be their goal. Can I maybe suggest that to them, during our interview? I understand you want to maintain your current weight. Do you think that's an appropriate goal to work for? And some will say yes, and some will say no. And especially when I've dealt with the diabetics, they don't care about their A1C. They're going to eat what they want to eat and when they want to eat. So there's that. We all have those residents. And so I personally tend to shy away from goals that have I will consume at least 50% or more of my food, only because whoever's doing that documentation, it's a subjective manner. In my opinion, what's 50% to me may not be 50% to another person, and it really depends on what their food preferences are as well. And then we come to our interventions, which is part of our monitoring and evaluation of our documentation. But our interventions need to match up or line up with our goals. So standard of care interventions. I had a surveyor one time say every single person that comes in is going to get a prescribed diet. Every person's going to be weighed per our protocols. They're going to meet with the RD quarterly and PRN. We're going to offer them an HS snack because that's a regulation, and we're going to monitor their labs quarterly and PRN. So should we add these standard of cares, just as they are on the screen today, into the care plan just to add more interventions to make it look good? Because I can remember back in the day when care plans were printed out, and the messier they were, the better off you were as a facility, because that meant that things were happening with this resident. A messy sheet of paper was a sign of care, but now everything is electronic. So there's that tracking episode. So if everybody is offered a regular diet, we're monitoring their weights, do we need to put that as an intervention? And that's a question to ask your facility as well. So part of the interventions is, again, wording it to the person-centered, and it's starting with provide me. I prefer X, Y, and Z. Provide me with my adaptive equipment of large handled silverware, etc. And honor my food preferences. I do not like milk. I do not like water, whatever those cases may be. It's using it in their words. So back to that care plan from that CAAS example, I've got that mechanically altered diet. I've got them on a supplement due to a gradual weight loss, and they got some chewing and swallowing difficulty. And here is the care plan. So I've turned the problem into being, they have a lifelong habit of not consuming breakfast. So they're only going to eat lunch, they're only eating lunch and supper. They have a diagnosis of hyponatremia, which needs to be addressed, and I have a variety of supplements. I do not wear my dentures, and I require mechanically altered diet. And I've had a coughing episode on food or fluid on the following dates. And they have a head wound with a wound vac as of October of 2020, and they are on palliative care. So I have lines kind of separating these three goals. And the first one talks about the weight. Oops, geez, what have I done? That they want to maintain their weight. We're going to encourage them to salt. We're going to encourage them to participate in the resident-directed exercise program that is set up. The next goal is I will consume the supplements that are ordered through the next review, because I can easily check that documentation because it's on the Mahers and TARs, and the supplements that are being offered. And due to the current status of choking or coughing episodes, and working with the speech therapy, created a new goal of not having more than 5 occurrences of coughing while eating or drinking through the next review. And then I list out what the speech therapy has recommended for that resident to have safe chewing and swallowing. I don't know how your tray tickets are set up or how staff is notified in your facilities of how to assist a resident in speech therapy recommendations. Our tickets at my facility, they do list out these approaches as well. However, I like to put them in there for the fact of the matter is that if our tray ticket system goes down, how do we know how to assist that resident? And it's about going to this care plan. I've also had a person in the past say, if I covered up the resident's name and I looked at this care plan, I would know who this resident is because it's so individualized to them. It's not a canned care plan. And I know Point Click Care has those options of the canned care plans. And where I currently work, we don't necessarily have canned care plans. So you are literally doing a care plan from start to finish on your own. I've attached the nutritional critical element pathway. If you have not used this tool, I encourage you to take a look at it. Because you can take any resident that is a high risk and ask yourself these questions, and can you answer these questions for any particular resident, especially if they've had a weight loss, if they're enteral feedings, that sort of thing. It's your checks and balances for DIA. Another page, and as you see, I have highlighted, is the care plan relevant? Are the interventions relevant, and have they been identified and implemented to try to stabilize or improve your nutritional status? Does the care plan identify the resident's individualized goals, preferences, and choices? And how often are food and supplement intakes monitored and documented, that sort of thing. So again, I encourage you to know your facility's policies in regard to any of the nutritional statuses. Then I move into monthly charting and any changes in the resident status. I used to work for a company that it was you touch the patient, you touch the screen. And so it's kind of the same mentality here is if there's a change in a resident's condition nutritionally and I found it important to document, I need to find it important to go into that care plan and make sure that it's up to date. So when we have significant weight changes that we're assessing at the first part of the month, and I know it's a busy time, the first part of the month is always hectic for everybody to get everybody's weights assessed. And I have recently started doing this in the last handful of years is part of the problem is adding that they've had a significant weight gain or loss and the amount. So that way when I go into that care plan, I can trend it. I can trend that resident's weight changes for that 3-month period, and even when we go back to a comprehensive assessment, and then I can just make a blanketed statement for that new care plan, just stating they've had a significant weight loss or gain throughout the year of 2020. That sort of thing. And this is where I've also found documented if that PCP has prescribed that weight loss as well. I just really like the care plan in this aspect for, it's just that snapshot. I don't have to go through 5 or 6 of my RD notes. I can go straight to that care plan and see that physician prescribed that weight loss back in November, or they were on an appetite stimulant to help gain weight at that time. Skin impairments. So this is where we can add maybe our nutrition interventions to a skin care plan. Hook up with the nurses and see if they have a skin care plan developed. But the key thing is that if you put something under that nurse's care plan, is please remember to go in and either DC the intervention, that sort of thing, because you don't want it to be a year down the road and you realize that this person's getting a supplement and they've actually been off the supplement for many months because we forgot to take it off the nurse's skin plan. But again, under the problem area, I will just put, I have a stage 2, whatever the area is, and then the month and the year. Once it resolves, I can go in and I can put resolved as well. Some interventions, and then interventions, your egg daily, whatever you choose to do, provide your house supplement per the PCP orders. But just remember to resolve the intervention if you do not, if you place it under that nursing skin note, or even your own nutrition note. It is our policy as well, and it's just been my form of practice to document on skin impairments, enteral feedings, and dialysis patients monthly. I know that there are times where there are no changes to somebody with enteral feedings, but I just remember it being very helpful when it came to my quarterly assessment time that I've been tracking this person. I know what's going on with them. I don't have to spend 45 minutes reading 3 months worth of notes for my enteral feeding person. I can go directly to my notes and have a recap because I've been doing it every 30 days. So your enteral feedings could have more than one goal. I don't know. Should you put the formula brand and rating of feeding into the interventions? I don't know. How much time do you have that if that feeding changes to go back in and change it? I don't know. It's kind of, what does your facility want again? And there should be some standards of cares with that. Everybody's, if you're on a tube feeding, you're going to have your head of your bed elevated while the feeding is running. Is it that facility's standard of practice to check residuals? Just what are the standards of care in that particular facility for enteral feedings? And what makes this residence care plan different from another enteral feeding? If you have 3 enteral feedings and you lay them all out and cover the name, can you tell which resident is which? Here is a sample of somebody that is on enteral feedings, and they are offered comfort feedings. So as you can see under their problem, why they're on a tube feeding and when the tube feeding was placed, then we're offering them comfort foods of puree and level 2 thickened liquids to promote their quality of life. But they've also had a significant weight change identified, a weight loss and a weight gain. So the goal is to not experience further significant weight changes and that they will not have aspiration pneumonia through the next review, and the interventions are listed. So again, what is your facility wanting? What are you comfortable with having on that care plan as well? Are you going to be able to defend? And I know Kathleen's going to talk about litigation in a little bit. So, and then dialysis. This was something new just in a handful of years ago. DIA was asking, are you talking with the dialysis center? Are you calling the dialysis dietitian monthly, quarterly, or PRN? Are you getting their labs from dialysis and their care plan timely? Because they have their goals happening, and we have our goals happening. So how are you networking with that dialysis dietitian? And I found it very helpful to have write in the chart, who the dialysis dietitian was, and their phone number and extension. So that way it was just easier to find. And I had put it under the problem. I had created a separate nutrition problem just because it's a dialysis situation, and I would put that contact information and I would do a follow-up note. So, and then I would tend to ask the dialysis dietitian as well, what are their goals there, and how can the facility help reach that individual's goal and be successful while doing dialysis. Some other considerations that may occur in between assessments is, they had a chewing or swallowing episode. You've seen on my example that individual had 4 or 5 incidences, and I put that under the problem because, again, I want to know how often did this person have an issue, because did we go 6 months without having any concerns with chewing or swallowing? Fluid restrictions come and go as well. And sometimes, strong food preferences and allergies can creep up as well. So evaluating, when you're doing your assessment, how are you monitoring your interventions? How do you know if that supplement is being consumed or not? Most of the facilities I worked in had the insures and the med pass and all of that on the TARs. But a lot of times, they're not having the magic cups and the enhanced cereals or the fortified foods that are coming out of dietary. How do you know what they're consuming, and how do you know if that's effective? Are you putting it somewhere in your note also that the nutrition goal was met or not met, and the reason why? I don't recall a point-click care, and I'm sure it does. I just know our system that we use currently, you can put a progress note or link it on whether or not the goal has been met or not met. So again, how are you monitoring and evaluating what's working and not working? I did add this slide last night. This was something I used a couple of my facilities because, again, how do I know that they're eating the ice cream at lunch and supper? How do I know the magic cup is effective? Yes, it was one more step for people to document, but at least this was my evidence to support whether to keep somebody on that fortified food or not. Again, this was something that I implemented at a couple facilities, and I could also trend that, yep, this is not working, so let's try something else. So from that CAAS example, this is at the end of my note. I've got my nutrition diagnosis all typed out, and then my nutrition monitoring, and I spell out for the nutrition care plan goal. The weight will be X, Y, and Z. The care plan goal was met, and we're going to continue that. I'll consume the next goal was about the supplements being ordered, and per the documentation, they're consuming 100%. We're going to continue that. And then due to the increased swallowing difficulty, the following goal was added. I will have no minimal occurrences and will continue to monitor weights. And then my signature. So again, when I've come to that call, I can just copy and paste that little paragraph of the nutrition diagnosis into the analysis of findings and state whether the goals are going to be implemented or not. And we've all dealt with COVID in one way or another, and a resident tests positive with COVID, that is a change in status. And so so I have been putting the problem of testing COVID positive. I don't want their nutrition status to be compromised and their weight will remain stable, and the interventions that pertain to that resident at that time. You know, I'm sure many of you have had to start supplements as well for residents that have been COVID positive. That sort of thing, or they've had increased chewing and swallowing difficulties, so more things need to be addressed. And then hopefully after a few months, that goal or that problem can be resolved, and I can put that in my assessment as well. I also said that we need to have a baseline care plan within 48 hours per the regulations. I'm not quite for sure what a lot of nursing homes are doing right now, but this is taken from the Nursing Home Association, the American Association. And nursing normally fills this out. I don't know what you guys have been doing out there, but this was something that I created for the dietary managers at the facilities I had consulted at, because, you know, within 48 hours, we're not always in that building when that admission comes. And so, so I just made it a blanketed care plan that the dietary manager could help figure out what the residents' goals were within that 48-hour time frame. I kind of ran through that pretty fast, sorry.
No, that's okay. Then we can have, I think there'll be a lot of good questions, Amy. I first want to tell you, I'll turn my camera back on here. I want to tell you, I think you made some dialysis dietitians very happy today. And I think you're completely right that while it does take extra time for us to reach out to those extra entities, that's how we really get our best care. And dialysis dietitians will tell you they want the dietitian at the long-term care facility to reach out to them and collaborate care. So one of the questions we had, I guess to go along with that, would be hospice. If they're on hospice, we should also be reaching out to them. And because the resident has chosen hospice, we would want to collaborate care with a hospice provider. The question was, if a resident is on hospice or palliative care, often weight maintenance is not, you're not seeing that. So they might have some insidious weight loss. How would you address this in the care plan? And I'm assuming they mean particularly as a goal, because staying within the usual range is not often an appropriate goal. What goals have you written for hospice at that point?
So that's where, you know, talking with the resident and the family representative, you know, what do they want nutritionally for their resident? Because it is disheartening to keep getting a weight that, you know, their loved one keeps continuing to lose despite every effort we have made. And I've had some families that say, I just want my loved one to eat as best as they can. And what is their best? You know, is their best just eating a few bites? You know, and and so that can be a new care plan goal with it defined with what did they say. And if the family is just wanting them to eat bites at meals, then their goal is going to be met. But it's definitely involving the resident and the family and just laying it out there. And what is hospice? You know, what is the medical director for hospice thinking? Because there are times where it's just too uncomfortable to weigh that resident, even if they're bed bound. You know, staff is going to have to get them on a lift them up, zero the bed out, and put them back down. Is that comfortable for the resident? Is that something that hospice wants to do? I know they have their own ways of measuring, as we all do, and Sometimes hospice wants that weight. So, but it may not have to be a goal for the resident.
So maybe even if it's not a weight goal, then maybe it could even just be, maybe I will be satisfied with the nourishment provided to me.
Yep.
Another review. Thank you. Also, I think there's some good points too about what if you have, you have I thought that was nice that you included the COVID problem. What if you have like your MDS nurse already has a COVID problem and someone commented that they add on interventions to that? You want to speak to situations where a dietitian may not have to create their own problem and be collaborative. I think you kind of showed that on the website, how you can add different disciplines to interventions.
So that's great that your facility has that, that MDS coordinator was proactive in putting in that COVID problem and goal. And absolutely, I would add to that instead of recreating the wheel of care, because I don't think I had many of my slides have the discipline column. But reality is the RD isn't, it takes nursing, it takes RTWs, it takes the food service and social workers. It takes out a lot of people, a lot of different interdisciplinary team members to make an intervention happen. So tagging on to a problem that's already established by another discipline, I sure would. I would just have to remember to go in and resolve the intervention or whatnot when the time came to review that.
Fabulous. Here, let me get back to some more questions. Is completing the CAAS in point-click care required? If you complete and address these MDS triggers and concerns in your progress notes.
I've always been taught that section, cause number 12, and I'm sorry, I've lost my train of thought on the CAAS numbers. For the tube feeding ones, is the dietitian's responsibility. And again, maybe it's just going in there and saying CRD assessment and the date, and not, you don't have to write a long paragraph. Like I said, I just copy and pasted what my diagnostic was, and I wasn't rewriting what my assessment was. And due to time crunches, and I understand that as well, I've never had any issues just putting CRD assessment and the date. So,
yeah, do you find sometimes that when you work in different facilities, you do things differently based on what the requirements of that facility or corporate company is?
Absolutely. It's just knowing that facility's policies and knowing what they want as well.
What that MDS coordinator wants.
Oh yeah.
Be friendly to your MDS coordinator.
Yes.
Amy, do you put behaviors into your care plans as well? And maybe along with that, do you want to talk about maybe the RAI Manual and how the CAAS resources at the very end can be very helpful when you're putting information into your CAAS and into your assessment in general? Do you address behavior?
I totally lost track of everything you said, Andrea, and I apologize.
I put too much into it. Because
I'm reading the comments from Ashley, the question. And so I don't know how much facilities use the shared risk agreements for when residents are refusing the textures and all of that, and the education's been provided. If your facility does use that type of thing, it is part of the care plan that they have a refusal of treatment or a shared risk agreement, whatever that facility used that's been signed by the medical provider and the resident or the family, depending on their decision-making capabilities. It is, I do put it as part of the care plan because that is pertinent, because if you as a dietitian leave that facility and the next dietitian comes in, how are they going to know these things? And that's the other key point. Your care plan is I mean, it's the Bible to that resident, in my opinion, for the next RD. And I've left facilities as well and had other dietitians follow me as I followed other dietitians as well. And that's where I've originally go to see who that resident is.
I love that. So the behavior question said, do you put behaviors into your care plans as well? For example, how would you discuss care plan a resident that is non-compliant with a texture-altered diet or is non-compliant with their discussed goals? Or even if a resident tends to throw their food?
Well, I would hope that social workers have some sort of behavioral care plan goal and problem addressing some of these behaviors, because then I could tag team with them with that behavior as well. Because some residents need to have behavioral care plans, behavioral plans. Like, I mean, one resident that I currently serve, they cannot have food in their room at all. Or their plan made by mental health for people. I mean, we involved everybody in that. So hopefully there's a care plan started for a behavioral resident, and you can team up with them and put those things in there. Because maybe it's given to the resident one item at a time, and that would need to be care plans. So the RTWs or CNAs understand that you give one item at a time. I don't know. That's how I would address it, I guess.